how do we use Notify in our conversation? So we'll say an initial visit for the nodule when giving kind of what the guidelines would recommend. I'll risk stratify them, and I'll say, here's your risk of cancer, and this is currently what the guidelines recommend we do next, and here's the risk and benefits of those. And we have a test available that's very easy that can potentially help us sway whether that risk is higher, which would mean we would do X, Y, or Z, or lower, which means we would do X, Y, or Z, typically surveillance, right? And so I think that we should come up with a plan of what you would want to do and add this test and see if that changes our plan. And 75% of the time, roughly, it will, right? So that's kind of how I approach it on the front end. On the back end, so let's say we have the same case and plan agreed upon was patient didn't want to do a PET scan for whatever reason. They didn't want a biopsy. They just wanted a CAT scan in 3 months, okay? So that was their decision. So we order the CAT scan in 3 months, go ahead and order Notify. I get those results, and let's just say roughly a week. Those results come to my inbox, I have to address my inbox. And so, after hours, I'll go make a quick phone call and say, hey, remember that blood test we ordered? Your risk was 35%. It's less than 2%. I think we're right on. Survey CT is absolutely what I recommend with strong confidence, and so we continue on that path. Flip side, CDT is positive. Your risk now is up to 70%. I absolutely disagree with doing a survey. I think we need to either biopsy or PET scan, whatever you feel comfortable. My preference is biopsy on those, and then we move forward. I do think that giving a little bit of education about risk. So I do tell them that if you're very low risk, this is what it's very simple. We're just going to follow with a CAT scan. If you're high risk, it's very simple. We're going to biopsy or resect, right? It's just we just don't know exactly where to find the middle ground. And I have patients that can be 15% risk and 45% risk, and the 15 is the one with cancer, and the 45 isn't. So that's why it's such a discrepancy of what to do next. And so I think they get excited that there's a super easy test that may help them get out of those categories, because nobody wants to do a biopsy, right? Or go to surgery if they don't have to, or on a benign nodule. So if we can downgrade them, which is majority of what will end up happening, they are super excited about that. So I think the feedback from patients is definitely very good. Yeah. And then I think the indeterminates, like I said, it's been an evolution. So initially, indeterminate was like kind of, like, darn it, sorry, it didn't really help you. But nowadays, the indeterminate is, okay, we know what indeterminate is telling us. And so indeterminate means that 15% isn't something we should just say, oh, it's, 85% likely it's not cancer. I wouldn't use that verbiage with that patient. It gives a false sense of reassurance and say, I'm kind of concerned that there's not enough inflammation here to make us feel comfortable that maybe just watching it is the next best step with a CAT scan. We need to either commit to one or the other, either a PET scan or a biopsy.
So when I get the results from Notify, I'll go over this with the patient, how this initial number was calculated based on the size and the smoking history and all of the features, and then I discuss the test, where we end up, so if it went from, 20 or 30% down to, whether it went down to 10% or went down to 1%, and I explained that it brought it down to this number. If it brings it down to likely benign, well, that's great. And, I can discuss that and say, now with these numbers, I think we can feel comfortable to just observe and do a follow-up CAT scan in 6 months or whatever. If the numbers go from 40% down to 30%, well, that's a different kind of conversation. And I say, well, the good part is that it did bring it down, but it really didn't bring it down enough for me to feel comfortable altering, the way that we should handle it. And in those cases, we'll most likely go on with the next step, whether that's a PET scan or a biopsy or a shorter term follow-up.
I utilize Notify results all the time when I'm talking with patients about the next step. If the Nodify test results, change management, I will call those patients and I'll say, hey, listen, I know we were planning to do X, but remember that special blood test that we got? Well, based on the results of that, I think that we should actually pivot and change course here, because I'm either less concerned about the nodule, and so I'm okay with repeating surveillance imaging in 3 months instead of a biopsy now, or vice versa. I know we were going to do a repeat scan in 3 months, but I'm more concerned and we should go after a biopsy now. When I was first approached with the situation, I was actually a little bit hesitant because I thought that patients would interpret that as me being indecisive, especially being a relatively new physician. Patients think the exact opposite. They are so appreciative that you have gone the extra mile, incorporated a new test with new technology, and had the humility to change course and not just let your ego and your pride stand in the way. So patients really, really value Nodify and any type of thoughtful risk stratification.